Hello everybody. Okay, could we welcome our next speaker? It's Georgina Craig. Thank you very much.
Hi everybody, lovely to see you. I feel very excited to be in a room with people and speaking live as opposed to being on Teams. So I hope you're all enjoying that connection again as well. So I'm going to spend about 20-25 minutes talking to you about video group clinics, and then we'll have the opportunity to have a bit of some questions and discussion perhaps, because I'm sure there's some of you in the room who've done some work with group consultations or group clinics. Can I just start off by just maybe a little bit of a show of hands if your practice or you have been involved in doing that? Just pop your hand in the air so I can just see. So we've got a little cluster down here. Yeah, a few people. So that's really fantastic. So before COVID, we were really focused on a face-to-face model of group consultations and group clinics. But as you can imagine, group clinics were basically the last thing on anyone's mind once COVID came in. And we had already decided that we wanted to do some work around the video version, but COVID really accelerated that. So where do I point this to? Doesn't seem to be working.
Side to side.
Okay, next slide. Can I say next slide and get you guys to do it for me?
Just side to side.
Yeah, it's not working. I don't. Oh, here we go. So over the next 20 minutes or so, what I'd like to do is make sure that you understand how video group clinics work and how they support person-centred care. Share with you what we've learned over the last year or so about when they work really well, and particularly some of the patient groups that they really seem to work well with. Help you to think about how you might use this way of working, understood some emerging thinking about what we call within a group clinic the results board, which I'll explain. And we're starting to see that sometimes with some group clinics actually talking about biometrics is not that relevant. So long COVID would be a good example of that, for instance, and I'll give you some examples of that. And then I've just got a few tips for you on things that you can do if you're interested in doing group clinics, which hopefully I will inspire some of you to do, things to think about to be as successful as possible. So this is how we set up a group clinic. We have these posters, and if we think about this little session as a kind of mini group clinic, how I would set that up with the group is to say, so for our session today, so first of all we're going to talk about video group clinics and person-centred care. Then we'll talk about how video group clinics work best, our emergency thinking about discussion boards, how you can apply group clinics. I'll cover the top tips, and then we'll talk about your next steps, because I'm going to get you to take some action at the end of this. And then we would agree with the group, and you would use these same understandings with your group online about how we're going to work together. So when you're facilitating a group clinic, it's really important that you agree this up front. And the reason is because if later somebody else behaves in a way that you feel is getting in the way of the group all doing really well and having a good opportunity to discuss, if you've agreed these group understandings with the group, it allows you to refer back to those and said, we agreed we were going to work this way. So these are the group understandings that we use in a video group clinic. So just a couple of things to notice compared to one-to-one, things that are different. So we tell them that we are not going to be recording the session and they must not record it. We ask them to mute their microphone and to use the chat to communicate unless we ask them to unmute. We tell them that spelling mistakes are really welcome. I don't know if any of you have tried to type in a chat when you're on a call. You usually make spelling mistakes, but obviously from a patient's point of view, the other thing about that is that there's some people who maybe are worried about, writing things down, making mistakes if that maybe they're not so confident about writing. So that just gives them permission to make mistakes. And if their technology isn't working, we ask them to just leave us a little message to let us know that, and then they can rebook into another session. So that's sort of how we set up a group clinic. And then we introduced this tool which we call the car park. And the car park is a way of putting information or questions or actions aside so that we allow the group clinic to flow. So I remember really clearly a little case study, and I think it was from our first face-to-face group clinic program in the Northwest, where we did a sort of a learning session at the end of the program, and one of the practice nurses had admitted that they hadn't set the session up using these tools, and then she said, we had a patient within our session who decided that it would be a great place to have a good moan about the practice, and started to have a real complaint about how long it takes to see the doctor, etc., etc. Now, because she hadn't got her car park, she couldn't say to that patient, do you know what, that's a really important issue. I'm going to put it in the car park and we'll get back to you and discuss that after the session, but we'll put it there for now so that we can move on with the work we need to do today. So these tools have been very carefully thought out to help you to manage the group dynamics really positively. So once you've set it up like that, you're going to move into being able to do your clinical work. Just to be clear, video group clinics are not a webinar. They're not a group education session, although education happens as it does in any good consultation. They're not a group therapy session. Usually, there's a very well developed practice in running group therapy and occupational therapy and physiotherapy. This is about doing clinical consultations that would otherwise be one-to-one. It's not a virtual peer support group either, but actually, as you can imagine, because patients are meeting other people in the same boat, they do get that peer support, but they're getting it within their cough review, or their long COVID care that you're delivering. And they're also not an expert patient-led intervention, but actually you're tapping into the wisdom of the group. And so their expertise is equal to the expertise of the clinicians in the group. They're also really person-centred. And when we say person-centred, what we mean is person-centred means it puts what matters to the patients at the heart of the conversation, but also it's a good experience for you as a caregiver, because actually, I don't know how many of you have done remote consultations, most of you in the room, I should think, over the last sort of year or so, but they can be quite draining. You can find yourself repeating yourself a lot. It can be quite difficult to engage with patients. Clinicians tell us they feel quite transactional quite often, that very focused on the problem in hand, not really so much a relationship-based approach. And that's one of the joys of group clinics, is that they actually allow you to really connect with patients, to really understand what's going on for them. They often disclose a lot more in a group clinic than they would do one-to-one. So it works well for you. You feel in control. You feel as if you're really getting to the bottom of the story about what matters to the patients. It's also about building on their strengths, and the key thing with a group clinic is, ironically, for the clinician to talk as little as possible. So what you want to be aiming for is giving the control back to the patients and allowing them to answer each other's questions. And you're just there to really top up if there's something that they perhaps don't know about. Just making the link with personalisation, which is obviously a big policy area that we need to think about. So particularly thinking about the additional roles staff that you've got working with you. Group clinics provide a great way of integrating them into your frontline delivery, and they support self-management, they support shared decision-making, and the group clinic model is based around a care and support planning approach. So all of those things that you are kind of becoming a bit of a sort of must-do in terms of long-term condition management is actually covered by the group clinic model. There are 3 roles. We've got our clinician, and for clinicians, really nothing changes. You know, you're still doing your clinical work. The difference is you're working in a group environment. And I was just talking to Kath about it before and saying the beauty of it is that you've got the group to give you that support. So if a patient is, you know, what often you find is that actually patients will, you know, be perhaps not complying with their diet. You know, maybe, you know, if they're diabetic, they might be drinking Lucozade or something like that, and somebody else in the group goes, oh, I don't think we're allowed to have Lucozade, are we, because that's got loads of sugar in it. And then that starts that conversation, and it's not so much a judgmental conversation where you're telling them stuff, they're more discovering it together in a group, which works really well. Then you have a facilitator, and when it's online we call them a technical facilitator, because they're going to set up the patients with their Microsoft Teams, they're going to consent the patients, and they'll do all of that before you join the session. So by the time you join the session as a clinician, all of that work has been done for you. And then in the background, and this is often the stumbling block, because you do need to get your practice manager on board, you do need to get the admin team in your practice on board. You have the person who kind of schedules the clinics, make sure that patients get their invitation and their link and all of those kind of things. We call that person the clinic coordinator. So this is how the sessions generally flow. This works really well online in exactly the same way as it does face-to-face. We do an introduction, we introduce the results board. I'll show you an example in a minute. The patients decide their questions for the clinician. Then the clinician joins the session, has the opportunity to answer those questions and also do any work that they've identified needs to be done with the patient. And then they leave, and the facilitator works with the group to set some actions. Yeah, so to, you know, what are you going to do before your next review to make sure your diabetes is better controlled, or, you know, your asthma care plan is implemented, or whatever it might be. So here's a diabetes results board. So what you can see is that it mirrors QOF. And what we've found is that when people do group clinics, QOF improves. So we've got evidence that QOF goes up by about 18%, 15 to 18% in the first 2 years, which is really, really positive. And most likely that is mainly because it stands out like a sore thumb if somebody hasn't got one of those things done. Yeah, and it motivates them and it motivates you as a practice to fill that gap in that kind of QOF framework. So, you know, for instance, if it's eye and feet check and somebody hasn't had that done, it's going to make them want to have that box ticked. So when do they work best? So they work best when you've got a lot of reviews, a lot of appointments, a lot of follow-ups to complete. Areas of care where there's a lot of repetition, where there's perhaps a sense of a bit of a tick box to complete. So the thing that is usually the thing that most practices focus on first is diabetes. Yeah, so diabetes reviews, because they often take up a huge amount of time. Second, respiratory. There's another area for you to think about of how you can use group clinics is if you need to build new skills and confidence. So if you've got trainee doctors, trainee nurses, if you've got students working with you, getting them to work with you to deliver your group clinics can be a really good way of them getting a really accelerated exposure to doing reviews. And also it helps them to understand what it's like to live with the condition from a patient's perspective, because the patients share their experiences, which is really powerful. If you've got a long waiting list or very limited practitioner resources, long COVID is a good example of that, isn't it? We've got already starting to get masses of long COVID people appearing, and the waiting lists, once the QOF gets up and running, the DES gets up and running, are going to be massive. And also if you've got high DNA rates, so if you've got clinics where you find yourself sitting around twiddling your thumbs for some of the time, I'm sure that doesn't happen very often in general practice, or if it does, you quite like those breaks because it gives you a chance to have a cup of coffee. But certainly in specialist care, that can be a really big issue. They might only have 6 patients booked in for the morning, and if 2 of them don't turn up, specialist nurses can find themselves sitting around for about half an hour or more in the middle of their clinics. And it gets rid of that, because whoever turns up at the start of the group clinic is who you see. And also where you want to build integrated working. So we were talking as well with some of the people here today about how social prescribers and practice nurses could work together on this, and it would really help you to integrate those personalised care roles. Or, clinical pharmacists, for instance, where you might be working on chronic disease management. If you've got patients who need a lot of reassurance, they really like the group clinic model. If you are, we're going to continue to have to be self-isolating and that kind of thing. People who are housebound. So anyone who might struggle to actually get into the surgery is a good group to think about. For those of you who've got lots of people who speak different languages, because it's a video model, potentially within your PCN or within your network, you might have a nurse who speaks the local language that lots of people speak. So you could start to run clinics in that language, because it doesn't matter where the nurse is, she can join via video. Does that make sense? So it's a great opportunity to kind of like build on the assets that you have within your PCN. And then anything that involves self-management, in making lifestyle change, all of these things are really, really supported by patients being in a group. So based on what we've learned over the last year, I'm just very quickly going to run through some of the groups of people that you might think a group clinic model, video group clinics particularly, would work very well for, and those where you might be a bit concerned about inequality. So it's really interesting, because we think about digital and we think, well, digital, it's kind of quite inaccessible for some people. Particularly, we tend to have our sort of bit of a stereotype in our mind about older people, for instance. And also, obviously, we know that there are people who struggle in terms of access to broadband and equipment because of what's termed digital poverty. And all I would say on that is, certainly in terms of digital poverty, that is definitely a big issue, and there probably is in GM a programme already in place to increase access and work in partnership with that programme. Usually it's based in the local authority, or it's a third sector organisation. They lend people equipment, and usually that equipment has got like a data attached to it, so they don't need to worry about data. That's a really important thing to build into your program design. But also on the digital skills side, just be really careful about stereotypes, because there's a lot of older people who through COVID have actually had to be able to use things like Zoom and Teams and things to keep in touch with their family. So actually they know more than we give them credit for, is what I'm kind of saying. So it is very much about working with each individual patient to find out where they are and how confident they feel. And it's also a great way of involving the family. So there's every reason why family can attend the reviews along with their loved one. And these are some of the people that we've found actually the video group clinic model in particular improves access for. And the one that I think it's really important to think about, some of the others are a little bit perhaps more obvious, is actually men. And men, particularly working men, are notoriously difficult to reach in terms of chronic disease management reviews. And actually they seem to quite like the video group clinic model. So there's every reason to continue to provide this as an option for people as we move forward. This is not just something that you should do because of COVID. There's some very clear opportunities to offer a way of consulting with us that people prefer to face-to-face and even one-to-one. So there's loads of ways in which people have used group clinics over the last year. I'm not going to go through all of them. I think you're going to get the slides afterwards anyway. As you can see, there's pretty much anything that you can think of is up there. So if you've got an idea and you want to pursue it, get in touch, and I will be very happy to either provide you with a case study where somebody has already done it, or work through with you and help you think about how you might do it. So, as I mentioned, this is how we've always traditionally thought of results boards, but actually what we've learned over the last year is that we can have a different approach where we really think of it more as a discussion board or a topic board. So these are some examples. This is a child development check discussion board. This is a pre-chemotherapy clinic discussion board. And here's an example as well of a well-being assessment discussion board where we've got patients looking at different elements of their life and thinking about those as opposed to biometrics. So don't limit yourself when you're designing your group clinics to thinking about biometrics. Think more broadly as well. So I'm going to just give you a few top tips to think about, which summarises what I've just gone through for you today. So when you're thinking about planning video group clinics, think beyond COVID. There's more to this than just responding to COVID. This is potentially a way that can really help you to offer choice and to engage groups of people who have previously been quite hard to engage. Think about working with your personalised care practitioners to make this change. Often they've got a little bit more headspace than the clinicians in primary care. They make great facilitators. Often they've already got experience of working with groups, and you can get them to be more integrated into general practice by involving them in this. What we've found from best practice is it's really important to get training for everybody who's involved. That's not just the clinical people, that's also your admin staff, your practice manager, probably a lead GP, as well as those personalised care practitioners. There's lots of free resources available, and I'm going to signpost those to you. We also run training 3 times a month, and it's virtual training, 2.5 hours, and that's something that potentially you can also tap into. Make sure you have a really simple benefit story. So when you sell this to patients, you want to make sure that you're really focusing on the things that matter to them. So you get to spend longer with your GP or your nurse. You can join from the convenience of your own home, and you'll get all of the care that you need in your review in one, and as well as learning from other people about how they manage things. Put in place systems so that you recall people to your group clinic as opposed to one-to-one. So where choice is important, it's also important that people make an informed choice, and they can't make an informed choice until they've attended a group clinic and compared it with their one-to-one. So that's kind of the way to kind of position it with patients. Start small, and don't worry if not too many people turn up for your first few clinics, because you have to get your head around the process first. Always do a dry run. So we found working with practices that the most learning happens when they do a dress rehearsal before their first live clinic. It's really powerful. Use technology to support patient recruitment, so send people texts, use AccuRx and all of the systems you've been doing to remind people about vaccines and all those kind of things. Your practices are really well versed in using all of those, so bring those tools and use them for your video group clinics. Send lots of reminders before the day, because that definitely does increase reduce the DNA rate. And have somebody on hand to help patients to join the first time. Ideally, maybe somebody within your team who's quite techie, who's happy to just be on the end of a phone, who will walk people through it. And follow the best practice guidance in how to facilitate group clinics, which is covered by the training, and use those posters that I showed you at the start of the session. So let's open it up to questions now, and if anyone's got any questions or thoughts or wants to share their experiences of running group clinics, and just to have a think as we're having this little Q&A session about what you might like to do yourself, what your next step might be. Have we got any questions? We've got a microphone, a roving microphone.
How many people would you recommend per group?
So what we're finding is that 6 to 8 people works really well for a video group clinic. With face-to-face, 10 is actually the ideal number. But what you will probably find when you first start out is that you might start a little bit smaller than that and then grow towards it. We have got people running video group clinics with 15 people, but 6 to 8, you get a really good conversation.
And how many sessions of group consultations would you do per week?
It really depends on the size of your practice. So if you were and your list size. So just as a rule of thumb, if you have around about 1,000 diabetics on your list, you probably need to be running 2 diabetes group clinics a week. And then you might also run a sort of one-to-one one as well for people who don't meet the criteria for a group, or who you want to follow up to give extra support or that kind of thing.
Thank you.
Any other questions?
What would you do about documentation?
Okay, so the question is, what would we do about documentation? So every clinician tends to find their own approach to documentation, but there's some sort of clear best practice around this. The first thing is that at the end of the group clinic, or if you feel comfortable them doing it, the facilitator writes a short summary of all the things that were discussed in the group, and that can then be posted on each patient's notes. And then what you can do as the clinician is just top that up with any particular points that are relevant to that patient only, or any actions that you took. So if you changed a medication dose, or if you reminded the patient about getting a flu vaccine, or you had to make an appointment for a flu vaccine, or all that kind of thing. So it's kind of like the whole group discussed this, and for this particular person I did this. Does that make sense?
Yeah. And also, how long does it take to kind of set it up each session, and then taking into account your time for documentation?
So there's a big difference between your first 3 and everyone you do after that. But after people tell us once they've done 2 or 3, they've kind of got it. They've got the process, and and then what you would do with a video group clinic, as a clinician, you would join very quickly, just so that you have been there, and check in with your facilitator, say 15 minutes before the group clinic, and then you would leave, and you would have the opportunity to prepare, knowing the 6 to 8 patients who are going to be there. So you could go and look at their notes, you could see what you needed to, you could make yourself a little note, right, this patient, I can see that their HbA1c is getting worse, maybe we need to change medication or whatever. that kind of thing. So you would have your little notes for each of the patients. Then you would join the group clinic, which would have been running for about 15 minutes before you joined, do your work, go away, and then do your write-up and take any actions that you need to do that you have, you know, sort of like generate prescriptions to be collected from reception or that kind of thing. So, you know, you're looking at maybe altogether with the review, participation and the sort of write-up, somewhere between 45 minutes and an hour to see 6 to 8 patients. Yeah, so you think about how long you have for one-to-one reviews, particularly remote one-to-one reviews, and think about how that compares. You can see there can potentially be some savings.
Yeah, I'm just thinking of it to the PM.
How to sell it to your PM. Yeah, how to sell it to your PM. So the time savings are big, yeah. Quaff impact, yeah. So if it's going to improve our quaff potentially. Other things. Who's had Kath? What when you've worked with your PM? What sold it to them?
I think supposedly back when you were not seeing everybody individually, you were seeing them all at once. So saving that way we did face-to-face ones, 20 minutes my time with each person, repeating a lot of the same information to each person, and then putting everybody in one group, then that time saving, I suppose. The patients really like it. I can say that. We've always got really good feedback, and actually we really liked it. We haven't actually done any video ones, but we did face-to-face ones. I'm quite keen to get video ones up and running. Just you know how it is right now. So
yeah. So sort of the staff fulfillment, the patient, better patient experience, improving the care. Those are the sort of things that tend to. I mean, the quaff one. I'm not going to lie. That's going to be a big one, you know. If you've got anything like, another one to just another little hook that you might want to think about. PCNs are going to be quite soon having to show that they're delivering digital consultations. So I think they're going to get some targets around that. So this would tick that box, yeah. So you know, and obviously tick it quite thoroughly because you're seeing 6 to 8 people in one consultation. So that's going to count as 6 to 8 digital consultations. So that's another good one. Yeah?
Would you go around discussing particular individual patients, which they would see a patient in front of others?
Absolutely, yeah, yes.
How would you get a patient that consented?
Yeah.
Somebody talking to this patient, that patient,
yeah.
and everybody's waiting until their turn comes.
Well, the way that it usually works is that you have a bit of a group discussion and then you go round and have a one-to-one discussion with everybody. And what happens is it's kind of quite fascinating because what happens is that the patients learn from everybody else's consultation. So, you know, people ask questions that other people wouldn't have thought to ask, or they might say, I've got this symptom and I don't really know if it's anything to do with my diabetes or if it's part of long COVID or whatever it is. And so a huge amount of learning happens because of those one-to-one discussions. So you often find by the time you get round to the last couple of patients that all of their questions have been answered and they feel really comfortable because so that's kind of the way it feels. But on the consent thing, which is a really important point, yes. And we've got all of that covered and signed off by NHS England. So that's really nice to know, the process that we've designed. And secondly, another thing that's really important that you know is that all the clinical work that you do in group clinics, video group clinics, is covered by professional indemnity. Yeah, so very explicitly in your I can't remember what you guys call it. That's right, NHS resolutions, it very clearly states that clinical work done in group consultation, in video group consultations, is covered. So that's a really huge stamp of approval for this way of working.
Would you get, you will need an appointment for bloods and blood pressure, pulses, weight checks beforehand?
Yeah, so you can arrange for that to happen beforehand, and then whoever does that can just book them into the group clinic, and then in the group clinic you're doing that clinical work. But I don't know if it's the same for you, but a lot of GP practices are now asking people to do their own blood pressure and things like that. So if that's the case, you know, you can have a way of getting that information fed in. But yeah, that's, I mean, in a way, if that's your system, that's the ideal, because, you know, you get them in for that appointment, all that stuff gets done, and then whoever does that, it's usually an HCA, isn't it, can book them in for the group clinic. I think there was another question over there, but I'm aware that time, yeah? Yes, there is. So it's, I'm going to suggest that I send Liam some links to send out to you after the conference. It's on the Future NHS website under video, in the digital first bit of NHS Futures. There's a video group clinic hub, and it's got a whole toolkit of how to, all the templates to run video group clinics. And I'm also one of the authors of some e-learning that you can tap into, and we can send, which is on e-learning for health, and you can tap into that as well, which gives you, you know, shares with you all the sort of nuts and bolts of how to run group clinics online. Thank you very much for asking questions. It's really nice when you're doing a presentation to get some questions as well, and all of them added so much value. So I'm going to hang around for a little bit if anyone does want to grab me and have a natter. So I'm here to help, and I think it might not work, but my email, if anyone wants to send me an email, is Georgina. Oh, send it to the ELC Works one there, info@elcworks.co.uk. And our website has also got links to all of those resources that I just mentioned, so you can get them from our website if you want. And there's also masses of case studies there that you can have a look at and get inspired by. Thank you very much, everybody.